Okay, thank you very much for the kind introduction. It's actually my pleasure to be here talking to you about my own experience with interdisciplinary dentistry. I was fortunate enough to work closely with a group of very talented dentists as a team from different disciplines: prosthodontics, endodontics, periodontics, surgery, implantology, and I was very lucky actually to be with them, and I've learned a lot from them as well. So basically, just to get this one out of the way, so I have no conflict giving this lecture. The learning objectives will be to illustrate the interdisciplinary nature of the dental care and to outline the role of different disciplines in dentistry in providing optimum patient care, and to demonstrate the importance of communication, which is a big word. Communication is very important, and I'm going to show you a couple of examples between different disciplines or specialties in dentistry and the provision of patient care. So I just would like to pose the question here to all the audience, and I believe you're representing all the disciplines of dentistry, and if there is anyone who think that they have the ability to deal with those cases on their own, and please do not raise your hand because they're going to spoil my presentation. So basically these are difficult cases, and you really need a team to work with, especially with the age group of those patients. They're very young, they're picked up very young, and you need to collaborate with all the dental team, paedodontist, all the way orthodontist, and then endo if needed, implantology, and we as a prosthodontists come at the very end. So I think coming at the very end gives us the right to actually be the one who plans the case, because I think things go wrong because when you receive the case at the end of the treatment, we find ourselves in a situation where we can't actually do what we're planning to do. And it's very frustrating for the patient. Say a patient goes through an orthodontic treatment for a year and a half or 2 years, and then they come back to you and you say, I'm sorry, I can't put an implant there or a crown. You have to go back and move the teeth a little bit more to be able to put a crown. It's very frustrating, and patients do not like it. So these situations could be avoided if we communicate more, basically. So for every complex problem, there is a simple solution, which is usually wrong. It's not the right solution. So I think the days of single surgery kind of practices have actually gone, and most people now actually into the polyclinics or multiple discipline surgeries, because no one would like to refer patients to an outside clinic because there's a good chance that you will not actually see the patient again and you lose money. So if you can keep the patients, that's what you should be doing. Teamwork, this is only a couple of disciplines which work closely related to the prosthodontist, and I'm sure there are other disciplines as well that I did not incorporate. And for every circle of those, I'm sure there will be other smaller circles, starting from your receptionist to your dental technician to your dental assistants. So these are all part of the team, and hopefully the patient is going to be here in the center of our care. So together, everyone achieves more. So why interdisciplinary care? Why do we care? So because I believe, and I hope a lot of you will share me this, that no one person possesses the range of expertise required to optimally treat all patients. And each team member has a focus area. So we have a fantastic team. A surgeon, he knows what he does. An endodontist, and then a periodontist, an implantologist. So they're very comfortable. This is their area of expertise. They've been doing it for years, and you get more predictable results. And it improves efficiency and streamlines treatment. As I said, there are no going back. Please go back and have some braces put back on because you need to move this teeth 2 millimeters, that's all. And it involves patients in decision-making process. As I mentioned to you that I was actually involved in an interdisciplinary approach. It's called special dental needs. And it was held every last Friday of the month, and we got referral from I used to work in Ireland, from all over Ireland, from specialists, not from the general dentist, from specialists who think those cases will need a bit more input from someone else, who's not actually, the treatment will be a bit out of the scope of that particular dentist, so they need a bit of help. So we get referral from all range, mostly orthodontic patients, and then we have those amelogenesis imperfecta and dentinogenesis imperfecta as well. So the patient comes in, and all the dentists representing the discipline will be there, and then they will all examine the patient, talk to the patient, and the patient is very much involved. So, and the patient can see what the treatment entails, and there's no quick fix solution here. If you start to do things quickly, you're likely to go wrong. So the patient is aware what the treatment entails, and off they go, and the treatment starts with whatever specialty that the team has decided to start with. And there's always a checkpoint. So orthodontic treatment starts. Halfway through the orthodontic treatment, the patient is referred to that team to have a look. Okay, could you move this a bit more? Tweak it a little bit more. No, go back during the treatment. And then the patient is sent back to complete the treatment. And then the orthodontist will not debond the patient before a final green light okay from the team to say, yeah, he's ready, take off the brackets. So, is there anyone from Ice Hockey Federation here? No? Good. So I can say whatever I want to say about ice hockey. So, in my views, the multidisciplinary approach is, as I said, the team kind of talks to the patient, and they all work together. The treatment is streamlined. So, in a way, they're more or less like those guys here, those guys here. So I have all of these big, muscular, good-looking guys, and we have this guy here, and he's giving instruction, So, and then they always get to this point, most of the time. Sometimes we have our drawbacks as well. Whereas in ice hockey here, everyone is doing his or her own thing without consulting other people. And then at the end, we get into difficulties, sometimes with the patient, sometimes with the dentists themselves. And there's this kind of a historical and ever-existing fight between surgeons and prosthodontists and who does what, and there's always this conflict. So in ice hockey here, there are a couple of features which are shared with the multidisciplinary approach, which is speed and slippery floor, As I said, if you start to be quick, you're more likely to make mistakes. And the slippery floor is the sound knowledge. If you don't have the sound knowledge, you're more likely to cause mistakes. And those mistakes could be detrimental. And it's not in favor of anyone to have those. Very interesting here, you can see this one here is the ball. I think in ice hockey they call it puck. Puck, yeah? So this could be our patient, and that could be our team. So the patient is not really at the center of our care, is he? So this is just to kind of make things, because I work in a sports dentistry hospital, so I'll have to relate to sports one way or the other. So interdisciplinary advantages and negative perceptions. It minimizes error for the reasons that I have actually already explained. It improves outcomes, benefits patients, and gives you that job satisfaction that you've done something nice, something that looks good, and your patient is happy. There are negative perceptions. They sound negative, but they're not. But patients see them as negative because you're paying money. Increased treatment time. The patient comes in for 2 or 3 missing teeth, and you say, no, you need to go for a course of orthodontic treatment and see you after 2 years. They don't like it. But it's our job to explain to the patient, to educate them, to explain to them that they need to do this. It increases complexity, as I mentioned. Increases cost. There's a lot of money. Orthodontists, do you have any orthodontists here? So, and then sometimes it makes some dentists will have the perception that it makes me look inadequate, So I'm referring a patient to a colleague of mine, and what would they think of me? They would think that I don't know anything, and that's not really the case. So it's always good to have someone that you can actually refer to, talk to, and it's always nice to have that feeling of a backup, get out of jail's option, where someone can actually cover your back when you make mistakes. So, and it doesn't have to be too complicated. These are post-ortho cases, simple, straightforward cases. young patients, they're not ready to have implants placed. The orthodontists have done all the job. I don't have to do anything. Midline corrected, teeth nicely aligned, just 2 resin bonded bridges here and there, and then everyone is happy. Those can be replaced with implants in the future, or some patients say, no, why change them? They look nice, I'm happy, so they keep them as long as they stay. So sometimes small things, this is not the same case, small composite build-up here. This tooth, the orthodontist, you could see, they were trying to pull this tooth up, it's not coming up. So it's like a primary failure of eruption. The patient is young, we can't do anything invasive, so you could just stick something over it to maintain everything. When the patient is old enough, you come back and you keep that door always open. So you always come back and then you modify things, adjust them, and if needs be, you can take out that tooth and place an implant in the future. Simple composite buildup. Orthodontists are actually great at moving teeth, but it helps them if they have reference. So if I refer this case to an orthodontist, it becomes difficult for them to see that, how much should I move this tooth or how much should I move that tooth. But I, as a prosthodontist, if we do a diagnostic workup, try that in the patient's mouth. It looks pretty okay. You do kind of a bit of a rough build-up, send this patient to the orthodontist, piece of cake, bring everything together, then you can always come back and review. It's not really a big issue. Sometimes we support and facilitate paedodontist. So this is a young patient of mine. As you can see, she's smiling and she's hiding something. So this is people reflex when they have an issue. And she's young, but she's aware of an issue behind those lips. And if you look at her, that's how she looks. She has a condition, a minor version of ectodermal dysplasia. And unfortunately for her, she's missing 20 teeth. 20. So she only has 4 permanent teeth. And these are all baby teeth that are overstaying their course. So again, to make her look nice, you could just make an overdenture. We're not doing anything invasive here. Just an overdenture over those teeth. And the adaptability of those patients, the young patient, is actually amazing. You put the denture in, and they just chop, 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 and then they're happy. And then she's smiling again. So, and it works both ways. Sometimes as prosthodontists, we have this kind of forward concept. Sometimes we deal with teeth that are badly broken down, and if you put a crown over them, they're going to break. So you seek an orthodontist to help to extrude the tooth a bit of crown lengthening, then you're engaging the tooth, and then that improves the long-term longevity of the restoration. Because if you don't have furud, you either have to create it or change your plan, because that tooth is going to break, because you're not engaging the sound tooth structure. So this is a patient of mine, and I'm here actually to show you my failures as well, so it's not to show all the success, but the failures as well, because I learned a lot from this case. And to put it in perspective, this case has actually made it into the undergraduate, they call it case learning sessions, brainstorming sessions. So he comes in, he's a very serious looking man. He's a firefighter, and he received a horse kick to his teeth. So he lost his central and lateral incisor. He's wearing a spoon denture that he hates. He has a very severe gagging reflex. I have not seen in my life someone who gags like him. You show him the mirror and he starts gagging. So you can't really do a proper examination of him. And he had a horrible experience extracting 1 molar tooth, and he hates going to the dentist. So you have all the red lights flashing. So he came in, all he wants is something fixed because he can't wear this thing. So as a prosthodontist, I did the workup job, basically mount study cast, diagnostic wax hub, and then a surgical stent, because it's an implant case. We have a bit of a concavity here, so we need to do a bit of bone graft, slight over-eruption of those that can be dealt with easily. You can see that canine is a bit kind of distally tipped, so you can watch for the root where it's going. So small things. This could be a straightforward case. And then off I go, I referred him to a surgeon. And then 9 months later, that's what I received. So the instructions to the surgeon were very clear, written instructions. Please place 1 implant in the central incisor area, because this patient has a class 2 division 2 malocclusion, So his central incisor was inside and the lateral was outside. So there was an issue of space mesodistally. So difficult to fit 2 implants. And then he decided to place 2 implants. So that's the X-ray. So these are 2 implants very close to each other. They're almost like kissing each other. And the scary view is this one here. So I have made a bad situation, or the surgeon has made a bad situation worse. So, and then you was going to lose. It's so basically, when I saw this patient here, just to put in perspective here, we kind of violated the biological width here with those 2 implants, and we lost the bone. And if you lose the bone, you lose the soft tissue. So the bone sits the tone, and the soft tissue is the issue. So if you don't have the bone, your soft tissue is gone. So when things go wrong, we all lose. And I cried. And then I severely cried. And then I spoke to my colleagues. And then they cried as well. And they started kind of discussing this. How did this happen? Who did this? How can we solve this? And there were a bit of kind of hardliners, do not treat this patient. Send him back to the surgeon. Let him deal with it. So it was a bit of a chaos. So I remember this ice hockey thing, and that's how our team was.
He's not in a position to control that rebound, and Lucic buries it.
Now everyone is fighting with everyone. No one is winning. Everybody is paired up. Did you hear that? So they're all fighting across the board, and they actually did not realize that fighting is legal in ice hockey. Believe it or not. So it's okay, and whoever falls first gets out. So for some reason, I don't know. So there was a bit of a problem. So what to do then? Very extreme nervous patient, hates going to the dentist, and at this stage he hates the dentist. He hates us all, and he has severe gag reflex and does not want to go through surgery again. He made it very clear. You're not touching me. You're not doing any surgery again. I gave you a chance and you spoiled it. So you have to explain the situation. We can fix this, but it will entail refining back those implants, a graft, block graft. We're going to make a scar here to get a piece of bone, and then maybe a scar there. So do not do that. He was very clear. So we had to make up for the situation. So he received the full refund because it's a mess up. We can't actually charge him for this service. And then we had to accept a compromise. So basically, I couldn't actually place my impression copings here to make the impression for him. So I had to use UCL abutment, join them together, come up with something. And you can see here how those implants are close to each other. So it was a bit of fun to make the impression for him, because I was working in a floor where there are actually 40 other dentists working. So there are 40 surgeries. And he gags, and everyone knows that I was making impression for this patient. So I looked really bad, and it's not actually my fault. But sometimes you have to stick up for other colleagues as well. So we made the impression, we spoke to the technician, he said, sorry guys, I can't do anything. So we had to actually bury one of those implants in a very primitive way. So I had to actually encourage some bleeding here and let it heal, and then that implant is gone. Well, gone, not fully gone, but it's just covered by, the gum healed over it. And then we proceeded, and then we ended up with the situation. I've actually messed up as well. I could have done a bit of pink porcelain here just to make it look nice, But he doesn't really care much. And I think that was our, that's how we got out of jail. All he wanted to have something fixed, and this was fixed. And the problem with implants is you always have one chance. If you mess up to come back is very difficult. So this is the situation 7 years later, and this patient is chasing me wherever I go, So there we go, 7 years later. So this is where we started, a denture. This is where we kind of, after the fitting of the procedure, a couple of months, so we had a bit of a refill here, but we lost the tissue here. And this is 7 years later. You can see this guy is peeking at us. No major treatment is needed, but he needs a bit of hygiene and all of that. And he, as I said, he's happy. But I think this is a failure on our behalf. This is a failure. This is where the breakdown of communication takes place. This is another nicer case. She was picked up when she was young, and apologies for the quality of those X-rays, because that's how I got them. And then she had impacted canines, 2 impacted canines, and they caused severe resorption to the central and lateral here, and then to the lateral here. And the canine was way forward. It's in the position of the central incisor. So I have nothing to say with this case here. It's primarily an orthodontic case. So we have the orthodontist. And she said she's very little, young. She's little. She's small, short, but she's very talented. So she said, I can bring this into the position of the central incisor. We knew this were going to go. So that canine was brought down in the position of the central incisor. And then it was camouflaged to look like a central incisor. Have I lost the? Okay. So that's the canine here. And the camouflage was done by my colleague, Dr. Sullivan. So that's courtesy goes to him. And then when the patient, remember this patient was picked up when she was very young. So implants were not an option. So you really have to maintain that patient for around 8 years. And she have to kind of look nice, or she has to look nice throughout. She's a young, beautiful looking girl, so she always will have something. So those teeth were kind of barely in there with the brackets. We're holding them with the wires until she was ready for implants. Teeth were taken out, implants go in, and then you have a prosthesis in place. Still, you could tidy up those things, but you know the door is open. You can always come back, tidy up things. So we haven't done anything major. This is another case. And I think this kind of all disciplines of dentistry have actually kind of were applied to this case here. This is a hypodontia case. It's a mild hypodontia. She's missing only 2 teeth. This is how she presented. She does not like the appearance of her teeth. Her teeth are very short. She's a good-looking girl. She does not like the spaces or the spacing between her teeth. And then basically, the clinic examination, case of mild hypodontia, missing 2 mandibular second premolars, microdontia, which is normally associated with hypodontia, short clinical crowns with gingiva showing when smiling. That's a bonus for us. Impacted maxillary canines. There's a bit of attrition and increased anterior vertical overlap. I don't know what anterior overlap is, but the orthodontist said no, she has a malocclusion or whatever, so I don't know. That's when you have people in your team. So basically, this is her X-ray. These are the 2 canines. Here we have the missing E's, I believe, the missing second premolars, and you could see the first premolars have actually tipped distally a bit. So it's primarily an orthodontic case as well. So the orthodontist goes in. So we work out the size of the teeth, and that's what we want to have. And then we ask the orthodontist, "This is your task," and the orthodontic treatment starts. So we have 2 impacted canines. The orthodontic is to optimize spaces, to align impacted canines, to correct the increased overbite. And in the treatment, 1 canine came down, so the orthodontist successfully brought 1 canine down. The other canine refuses to come down. So we had to go a bit more radical and have it removed. And then the periodontist comes in. We had a couple of root canal treated kind of treatment needed, so the endodontist comes in. So you have all of this back up, and I'm actually sitting in the backstage watching, and they're doing all of this for me. So everything is done, grafted. This is the tooth out, and this is after the root canal treatment, and then crown lengthening, and this is case ready for prosthodontic care, a bit of healing more. So when I saw this, I was whistling. I was happy. It's like easy money, very easy to fix this one. A monkey can do this, and then that's it. So basically, you prep teeth, you make the impression. These are the implant crowns. These are the provisionals in place. The provisional is actually a copy of the diagnostic wax up, so we knew where we were going before we actually started. And then you fit those crowns in. I'm looking at them. I can make this one a little bit more bulky. I can adjust a little bit, but you know, it's a pretty good result. So, and this is her before and after. Complete change of her lifestyle. She's kind of lost a bit of weight. She's looking great. She changed her hairstyle, her makeup, and she also changed her husband as well. So that's basically it. So hopefully I think that comes to. I'd like to acknowledge the help and the support from my colleagues where I was working, because I've actually learned a lot from them. And teamwork together, everyone achieves more. And I should put this one in. Thank you. right in time.
Fantastic presentation. We have time for a couple of questions before we break for lunch. So, any questions from the floor? Or is everyone hungry?
I think everyone's hungry. Ah, there is one. There's always one.
Just one question in the middle here. Gentleman, white shirt, dark suit.
So, thank you, doctor, for the lovely presentation. I just had a question on one of the cases you presented, the one with the bilateral impacted maxillary canines in place of the centrals, where you took out the centrals and the canines were mimicked to look like centrals.
Yeah, the orthodontist did. I did not.
Of course,
okay,
sure.
Yes.
But no, I know that's an orthodontic intervention. But sorry, I didn't get the X-ray right. But the primary canines were still present there, right? In place of.
Yes. Yeah.
So,
I think initially the primary canine was there. Yeah.
okay.
As
So
far as I can recall the case. How can I go back to this? Maybe going back this way. This one here, yeah?
yes, so I'm not very clear with the X-rays, but could we have retained the primary canines for a bit longer and, not put in the implants there? I'm not very sure the X-rays.
Yeah, the implants did not go in until the patient was, I think, 20, So
right.
this is a very early X-ray. So the
Okay.
canine was only brought in the position of the central
Centrals,
incisor.
yes.
And that lateral was actually kept. I'm
The
not sure about
primary,
that,
yes.
But I think by the time we saw her that primary, our aim when you're dealing with young age is to actually let nature do its job.
Sure.
Do not intervene.
Yes.
Because if you start taking out teeth and then you're not replacing them, you lose bone. So you're not
Exactly.
gaining anything.
Yes.
So always maintain what you have,
Sure.
make sure it's stable, and then you can always intervene at a later stage.
Right. No, so that's exactly my question. Could we have left in the primary canines for a bit longer, let's say 25, 30, 35, if there was no issue with the primary canines?
I think at that stage, the plan was we're not really benefiting a lot from that once we get that stage, because that canine can actually come loose at any stage. So if you're going to do a more definitive restoration, maybe it's time for it to actually go.
All right. Okay. Thank you.
Okay. Yeah. Okay. Thank you.
So